So we saw a whole list of complications, right from the time you start to plan to intubate these patients to the time you extubate these patients, and subsequently, you are in for a lot of complications. But that doesn't mean that you don't put these patients on ventilator at all to avoid the complications. So how do you prevent it? So you should be able to assess the airway well when you um, before you start intubating. Use the normally used tool, the Mallampati score, the Lemons system, to identify which score, which airway is going to give you trouble. Assess the airway well before you go ahead with your intubation, and make sure your equipment is always ready to go. And always keep plan B ready. Suppose I can't intubate the patient, what am I going to do? Am I going to use a supraglottic airway? Am I going to use a front of neck access, or am I using a bronchoscope? Whatever it may be, all this should be ready to go without running around when the problem actually pops up. We discussed about the effects of hypovolemia on perfusion, on hypotension, on its effects on other organ functions as well. So ensure euvolemia in all the patients whom you are going to intubate or immediately post intubation. Now, the process of extubating a patient or weaning a patient from ventilatory support actually begins at the time of initiating ventilatory support. If you choose an inappropriately small tube for a patient, they will struggle hard to breathe, and you will never be able to match their demand because the tube you chose has put a lot of resistance in the circuit. On the other hand, if you choose a tube that is bigger than what's correct for the patient, you could end up with the mechanical complications like stenosis and cord damage, which we discussed before. We already discussed about the adverse effects of drugs, their dosages, so you should know the drugs and their dosages very well. One of the principles in medicine is first do no harm. So prevention is the key. So if you want to prevent some of these complications, so you need to avoid trauma during intubation. Intubation should be very smooth. There should not be any panic, and you should be doing it in a very calm and controlled way. Make sure you have not intubated the esophagus and you check the endotracheal tube position. While conventionally we are taught to do 5-point auscultation, look for chest rise, and then maybe use the ETCO2. In a COVID situation, auscultating the chest is not recommended. ETCO2 has been made mandatory for checking the position of the endotracheal tube to ensure that is actually a tracheal intubation. We have seen the adverse effects of inappropriately set tidal volumes and inappropriately set PEEP. I'm sure monitoring the talk on monitoring of mechanical ventilation has addressed or will address these issues. So monitor your peak pressure and plateau pressures very well. Keep the head of the bed elevated to prevent the aspiration and to prevent the patients from actually regurgitating their gastric contents. We have already discussed the consequences of prolonged nasogastric tube insertion. So the preferred route of feeding these patients is by the orogastric route. Humidifiers. This is something which we all need to be aware of. Some form, if you are intubating the patient, you are actually bypassing the normal humidification mechanism of the nasal mucosa. So even if you put a patient on a non-invasive ventilation with oxygen requirement more than 40%, the higher oxygen concentrations and the flows that are associated with it will prevent the air from getting humidified by the nasal mucosa. So some form of humidification is mandatory. There is a choice for you in a normal situation to choose between a heated humidifier and a heat and moisture exchanger, but in a COVID situation, the heated humidifiers or the cascade humidifiers or the wired humidifiers are not recommended. You are supposed to use the viral cum HME filter on both the expiratory and the inspiratory limbs of the ventilator circuit. And there should be enough moisture in the endotracheal tube for you to say that your humidification is working. If you don't humidify the circuit, your airways will get clogged The lungs will collapse and you will be in deep trouble. But if you find that the tube is not getting enough moisture, change the HME filters when they are ineffective. There is no protocol for a daily change of HME filters, but usually they lose their efficacy between 48 to 72 hours. So you can have your own protocol for changing it every 48 hours or 72 hours, or if you have time and you have the manpower, keep watching the endotracheal tube. As and when the humidification lightens up, you change the filter. Feeding is the best form of stress ulcer prophylaxis. So if the patient is hemodynamically stable, does not require vasopressors, is tolerating feeds, feeding is the best form of preventing stress ulcers in these patients. So do not use proton pump inhibitors for all patients. There are definite criteria for high-risk patients, those who are on antiplatelet drugs, those who are hemodynamically unstable, requiring vasopressor support, those who require more than 60% FiO2. These are the patients who, or those who require renal replacement therapy, are the patients who are at high risk for stress ulcers, and these are the patients who need to be given routine proton pump inhibitors as prophylaxis. What needs to be routine is probably DVT prophylaxis. And by DVT prophylaxis, I don't always mean pharmacoprophylaxis. You need to have some form of DVT prophylaxis in all patients who are mechanically ventilated, and that could be a sequential compression device. The thromboembolism deterrent stockings, called as TED stockings, may not be the right thing to do in a critically ill, hemodynamically unstable, hypoxemic patient, because they don't actually prevent the formation of the thrombi in the deep veins. Transfusion triggers should be very, very clearly defined in your hospital and in your ICU or wherever you are working or intubating these patients. So, if the patient doesn't have acute ongoing myocardial ischemia, avoid unnecessary transfusion if the hemoglobin is more than 7 grams or the hematocrit is more than 21%, because transfusions not only worsen the lung injury, can also lower the immunity and cause infections to these patients. Recovery from mechanical ventilation is intrinsically linked to how well you have looked after these patients during mechanical ventilation. And that boils down to proper nutrition. A daily nutritional assessment, especially if these patients are on renal replacement therapy, they would lose a lot of trace elements. So keep a track of that and replace trace elements for these patients. Sedation breaks. If the oxygenation and ventilatory strategies permit you, it's always good to lighten the sedation and let the patient start breathing on his own to exercise his intercostal and diaphragmatic muscles. Avoid drugs which increase neuromuscular weakness, like aminoglycosides, like polymyxine antibiotics. So these are the drugs which can actually perpetuate or increase the risk of neuromuscular weakness at a subsequent stage for these patients. Fluid balance. Fluid balance is a significant independent predictor of prolonged ventilation. While hypovolemia is bad, hypervolemia or positive fluid balance is equally bad. So if your patient is more than a liter positive every day, his chances of successfully weaning off from ventilator support on time are very less. So pay meticulous attention to daily as well as cumulative fluid balances. Drying a patient out with diuretics is a less preferred option than avoiding a positive fluid balance. And that uh, is an important aspect which you should be monitoring. Tracheostomy should be done at the right time. Too early tracheostomy will cause a lot of morbidity, and a late tracheostomy also will not give you the benefit. So, in a non COVID situation, the 7th to 10th day seems to be the preferred time for doing a tracheostomy in a mechanically ventilated patient. But in COVID situation across the world, the literature seems to be suggesting that tracheostomy is planned maybe at the end of 2 weeks, at day 12 or day 14. This is what literature has shown. I don't have personal experience of tracheostomies on these patients. Infection prevention is the topmost um, topmost priority for these patients. So proper asepsis while you are doing suction on these patients is very important. So proper asepsis during suction or during handling the airway is an important aspect of taking care of mechanically ventilated patients. In a COVID situation, the risk of aerosol generation is very, very high. So in this situation, it is strongly recommended that all patients who are mechanically ventilated should have a continuous closed suction to prevent the risk of exposure of the healthcare workers to aerosol. We should get rid of this habit of instilling substances into the endotracheal tube like saline or bicarb into the tube to lighten the secretion. Especially in a COVID situation, you are putting yourself at an undue risk for aerosol exposure. Don't fiddle around with the circuit unnecessarily. Change the circuit only if it is soiled. Daily change of circuits has not been shown to decrease the incidence of mechanical ventilation, infective complications of mechanical ventilation. Avoid self-extubation. So keep your patient well counseled, well sedated, and a patient, you need to talk to the patient. You need to explain to them why the tube is in place, why you need him to be cooperative. Because the patient self-extubates, he invariably does with the cuff inflated. He will damage the vocal cords, and your subsequent re-intubation would be a big challenge.